It's different than if you are a nationally competing athlete who is under scrutiny for not cheating against your opponents here. That's for the enhanced games. So they'll welcome you over there. Thank you all for tuning into the next installment of our Peptide series. This one is the exciting Wolverine stack. So essentially, of all the peptide fun names out there, this one's the most well-known, tossed around a lot because the idea of healing like Wolverine, even if you're not a Marvel fan, is quite appealing. So there's some truth to this. There are some over-exaggerated claims in this one. There's some safety risks, and of course, the legal landscape for these things. So I'm gonna break it down for y'all and kind of walk you through how I look at these potential peptides, these therapies, where it's not worth going and where you should speak with your own doctor. As always though, in this one I'm going to put up front just because of the stronger claims in some of these slides, the dosing protocols that I reference here that have been used by others in the industry. A lot of these are off-label, are on certain FDA do not use lists. And so I want to make sure that everyone here understands that this is not medical advice. This is not a relationship between you and your physician. This is nothing more than educational and entertainment. But first, I'm Dr. Alex Watson, and I get people ready. By that I mean I get them ready for surgeries, cancer therapies, and fitness-based competitions. In this case, I'm going to get you ready for healing better and getting back to what you enjoy doing. All right. First one, most well-known one, most commonly used one, yet also lacking in a lot of research. We got BPC 157. And this one is derived from the GI tract. The cool part of this one is that it works in several ways that indirectly and directly support healing. So it's been used in a lot of cases for healing of different musculoskeletal injuries, rotator cuff tears, post-surgical recovery, those kinds of things. And it's endogenous use, so its use in our bodies is going to be one of repairing the GI tract. So it's actually from where it's derived. So the ways that it works here, kind of two main pathways we've identified. One is through VEGF, and VEGF is a different pathway in terms of generating more blood vessels. So that's why you're going to get down to another slide here in terms of the risks. VEGF signaling is also associated in a lot of cancer pathways. And the reason why is more blood flow equals more growth. When you're healing, that's a great access point for more nutrients, but other things that are growing quickly use the same sort of access points. That's one consideration when even giving a little attention to this peptide. Another important mechanism here is that it actually increases the ability for cells to migrate. So when you have fibroblast migration, you have these cells with stem cell type features get to where they need to be so they can kind of lay down some new foundation, rebuild injured collagen structures and those sorts of things. By having the ability to deliver more blood flow and the cells that depend on the blood flow to then kind of proliferate and grow and rebuild injured tissues, that's how you can get this healing pathway going on, which is real nice. That also implies, obviously, there's a synergy between those two pathways, which is why it can be quite potent anecdotally in recovering from injuries. And there's some research studies behind this one. Another cool pathway is that it stimulates the expression of more growth hormone receptors. So if you have increased receptors for growth hormone, tissues that benefit from that, such as those that will benefit from the collagen stimulation that growth hormone signaling does, again, synergy. You're going to have three different ways that injured tissues can repair and rebuild. So three pathways will work essentially to give you the building blocks through more blood flow, the highways to get there, so that cell migration, as well as the overall fertilizer, like growth hormone, to just do its thing and rebuild these tissues. There's also a bit of a homing effect anecdotally. The common anecdote that practitioners of BPC will use here is that you don't need to inject it locally to the injury. People usually do, if you can, but in a lot of cases, you just kind of put it in and then it goes to where the injury lies. So if you have some deep structure that you're trying to rehab here, and again, totally educational and informational, I'm not telling you to do this whatsoever, but you would put this locally, that could maybe help it a little bit, but anecdotal reports here say you don't actually need to really land that injection right next to the injury to have that benefit. All right, so where is the evidence behind BPC? Let's dive into that here. So in this case, we got some good and we got the bad, and as always, non-medical advice. So the first one, there are decades of research using BPC in animal studies. Now, they did have a trial in patients with ulcerative colitis. Again, BPC is derived from the gut, so it makes sense that we would use something like that there. And in fact, there actually was a significant improvement in these patients in terms of their bowel movement consistency and subjective symptoms, those things. So likely to have that local benefit that we're anticipating here. The one big red flag here on the other side of this slide is that there was a safety trial, phase 1, that's early stuff. Just basically start the medication or treatment or intended whatever, see if it causes harm before you start with the larger scales, the more patients, the heavier investment in funds. This one never got published, which is kind of strange. I mean, no one's, as far as I've seen, has been able to figure out why it died in the water like that, which is concerning, of course, because if there were no findings, it's one thing. If there were concerning findings, it's a different thing. So that gives everyone a little bit of pause here. The other studies available just had different areas of bias. So either no placebo control, so you can't tell what would have happened if the patients did nothing. And you also have a different study where there were potential conflicts of interest, as in this was kind of put together by physicians who sold BPC in their practice. So obviously you can't say that these folks are unbiased and their data must be interpreted with kind of that sort of, grain of salt there. So different protocols when people are talking about this in research setting versus clinical use. Researchers, they're going to use about 200 micrograms as their daily dose, whereas in kind of true athletic cycles for recovery or injury recovery as well, it might be in the realm of between 500 and 800 micrograms, and then a maintenance dose of 200 to 500 micrograms. This is all without a strong kind of research basis here, so some variability and some uncertainty in terms of have you reached the maximum efficacious dose? Are you crossing into concerning territories in terms of the dose and the exposure and everything because of that angiogenesis? So because of that blood flow, what else can be growing here? Because of that fibroblast migration, what else can be moving here? Because that growth hormone signaling, what else can be amplified here? That's where some of these risks lie and some uncertainties. The FDA put on one of their lists because there was insufficient data to say it was safe or not. That's their job. Can't really fault them for that one. As much of a bummer as that one is, I would like someone to just do the darn study so we can say once and for all, what are we looking at here? WADA, obviously they're going to ban this one if it does have any sort of potential benefit for recovery, and those 3 mechanisms tell me it does and could have other anti-inflammatory performance type benefits. They should and have listed it in their substances that are no-go. So what about pairing with growth hormone? How can this potentially give you some synergy? So like I was saying, that since BPC upregulates the growth hormone receptors here, then you're going to potentially get some synergy and can lower the dose of either one versus what you use independently. If you're going to have more receptors for growth hormone on the injured tissues, well, fantastic. Maybe use a smaller dose of a growth hormone secretagogue. We're going to review those later in a second, or something else in the same pathway. Okay. So who's going to be a good candidate for this? If they're going to try it and under supervision, yada, 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 say it's legal, all that good stuff, that would be folks with soft tissue injuries, things that maybe don't have the best blood supply. So these would be injuries to things like, obviously, the rotator cuff is a common reported one here. Different knee aches and pains, meniscus tears, things like that. Theoretically, you could have some benefit if you're going to increase blood supply to an area with decreased blood supply. After surgery, that's a very logical spot because when you have the wound healing, all those sorts of things, you're going to already have increased fibroblast migration. So supporting that, not a bad idea. Angiogenesis will help bring nutrients into those tissues where you just surgerize them. And then being that's derived from the gut, GI issues makes sense. That's why they even have some oral BPC formulas still, and those are actually orally active. One of the few that has some oral activity as opposed to the injectable ones. If you're doing it orally, dosing may be different. I have less experience there in this case, but you really are going to get more of a local effect. So it's not going to go as systemic. It's going to have its main effect in the GI tract, but if that's where your main problem is, you're not having a big systemic musculoskeletal issue, whatever that is, that might be all you need. And there's increased safety there theoretically because you're not going to have the risk of injecting things like endotoxin that would normally have some barrier against that with the GI tract, stomach acid, all those things. But if you're to inject BPC, even if it's mostly pure, but only a tiny little bit of endotoxin in there, you're going to give yourself a big inflammatory reaction. So in these cases, it's obviously best to, in the same vein of using as low a dose as possible to get the intended response with any medication, access and the means of administration, same thing. If you can get away with an oral formula because your problem is GI tract, likely safety is going to be more in your favor there. We've already talked about that cancer risk before, so I'm not going to continue that one here. I think you got the point. TB500, and there's a kind of related compound, thymosin beta-4. In these cases, these are derived from the thymus and are part of natural injury repair and those sorts of things. So the main area where it works here is it deals with cell migration again. So that's where actin comes into play. Actin's involved with some of the kind of railroad tracks of delivering things, delivering cells. By doing that, you're going to help that stem cell mobilization and, again, put the building blocks in place, kind of like the same concept of the fibroblast before. If you can get stem cells to an injured site, well, they can differentiate into whatever tissue needs to be there. So, theoretically, an injury in terms of cartilage damage, well, new cartilage stem cells can go in there, lay down some fresh cartilage, and facilitate recovery in that respect. Anti-inflammatory. This goes against some of the other discussion that we've had here, in which I've railed against RICE, the rest ice compression elevation approach to injuries. If you're going to reduce inflammation, well, that may reduce your body's own innate response to those injuries. In this case, it doesn't seem to be the case. TB500 is used for that exact purpose of kind of quelling that chronic inflammation and getting to the healing point. And I think it's because you're going to be able to offset some of the negatives here with the inflammation, just that simmering, dysfunctional, repair responses, lack of any obvious place to send these things that you use the acute inflammatory response to achieve. But instead, you'll be able to have just a better, more focused approach without all the noise going on here. Totally theoretical. Just reading between the lines here in terms of what we know about this one and the mechanisms and everything like that. But I put in big text here the safety that was demonstrated with this one. Is they blasted some adults with TB500 at these high doses, and it was like a full retrial. Didn't see any acute toxicity, so that's kind of cool. It should not be taken as a stamp of safety approval here. The FDA certainly doesn't believe so, but it does give us a little bit of reassurance in terms of the likely safety of this one in the face of everyone saying that it's going to give you all that same stuff as BPC in this one. In some cases, they paired it with other compounds. So you see it with different ulcers and unhealing skin injuries and things like that, especially when paired with selenium. You may see some improved response to soft tissue kind of wounds like the venous stasis ulcer there, diabetic wounds, things like that are where a lot of the research is looking right now. Again, these doses are not meant to be taken from here and applied immediately, but just for context, typical dosing is going to be in the 2 to 5 milligram range. Think back to the last slide there, as opposed to the over 1,000 milligrams that was shown to be safe when done for 4 weeks. So just the order of magnitude here difference, reassuring, but should not be a stamp of safety approval here. The frequency, every couple of days, 3 to 4, whatever. And usually if you're healing from something, 4 to 8 weeks is the typical on this one. The cancer thing I was hinting at before, in this case, there are mixed results in the research. Some suggest there may be a worsening of cancer risk, whereas other ones suggest that it may, probably from some immune modulation, reduce that risk. At the very least, it's a wash. Probably nothing. I wouldn't look in one direction or the other, but you always want to know where your blind spots are. So if there isn't even theoretical cancer risk, you better not have cancer if you're going to even look at this one just to be safe. There have been some athletes who actually have been in trouble with WADA for using this one. So this goes back to making sure that you understand where the risks are in terms of whatever your sport in which you're participating. If you're a weekend warrior doing this for funsies, it's different than if you are a nationally competing athlete who is under scrutiny for not cheating against your opponents here. That's for the enhanced games. So they'll welcome you over there. All right, so who might be using this one? Like I was saying, this chronic wounds is kind of where a lot of the folks are looking right now, especially in the context of diabetes and some of the changes in blood vessels that go along with that. And so that's where this might be beneficial in terms of modulating the immune system, so getting it to function correctly and not, the simmering inflammation, all that stuff, whatever. And selenium is important for some of the immune activity involved there. That would go along with the healing aspect. Selenium is important for some of the tissue regeneration enzymes there. in a similar way that vitamin C is involved with collagen cross-linking, that kind of thing. All right. And dry eyes, because as it was shown in the prior slide there might be some benefit there for dry eyes. That research is ongoing, and hopefully with FDA approval for that, it may open the door for other applications of TB500. But the same concerns of, is this going to get me in hot water for something that may likely be safe, but we can't say with certainty? Well, if once we have an FDA approval and a trial under our belt here, it should give someone a little more confidence in that one. All right, so back to that growth hormone. We already went through these in the couple different lectures before, so that the dementia one, as well as the best peptides for muscle building and fat loss, body composition, that's where growth hormone shines. But as growth hormone pathways do upregulate the activity of collagen enzymes and function there, it has an important role potentially in wound healing as well. So the growth hormone signaling, you see a 6-fold increase in tissue regeneration, collagen activity, whatever it is that you're looking at here in 14 days. That's pretty impressive with adequate growth hormone stimulation. Now, when you're taking just recombinant growth hormone, in a lot of cases, it's going to be either one or only a small profile of all the available growth hormones in the body. And so that's why, personally, I would like more safety and confidence in these secretagogues, peptides that increase the secretion of growth hormone, because that gives you a more typical profile of the myriad growth hormone variants to be released and give you the benefits there. There are two main secretagogue families. So you're going to have the ones that work on the ghrelin receptor and the growth hormone releasing hormone receptor. Ghrelin is also known as the hunger hormone. Do this a lot in my obesity practice. Stimulating that at the wrong time or too chronically is going to cause two big problems. You're going to eat a lot, and you're going to be anxious a lot of times during it too. So ghrelin being released when you're fasting or having, in search of food, really useful when you're a caveman starving and need to go on a hunt, because it's going to increase your alertness and these things. But if you're constantly stimulating that receptor, like this one non-peptide molecule in this family, MK6M7 or ibutamorin, that sounds great, except there was a pretty clear increase in anxiety and psychiatric distress, so much so that they actually use this in mouse models to induce a PTSD type phenomenon here. So in this case, you want to make sure that you're working with somebody, if you're even considering something like this, you're watching blood sugar levels, all these things, or you just work with someone to get something better and more tailored. That's where the other ghrelin receptor agonist, ibutamorin, is going to be my preferred method in that pathway, because it's shorter acting. You can do it, before bed. You're not going to be anxious and hungry, all day the next day. It's a nightly kind of thing. The same way we would do with Simorelin. But in this case, it is a very focused release of growth hormone and has some additional benefits of ghrelin as well, sometimes if done in certain pulses. There are some independent potential anti-inflammatory effects, and that's why it's kind of cool to pair these together. The peptides that work directly on the growth hormone releasing hormone receptor, those are Simorelin, those are Testosterone-related, CJC1295, the other commonly discussed growth hormone releasing hormone type peptides here. If you want more about the details and the differences here, I'd hunt back to the prior lecture on the body composition that we did, because that one I spend much more time on. That's why I'm not going to lightly touch on it here. Now, but the key benefits of pairing these two is that there is a multiplicative effect when you're combining the secretagogues that are in the ghrelin pathway as well as the ones in the GHRH pathways. So they don't just have an additive benefit, they actually stimulate they have legit synergy there. So it's kind of an interesting effect. They have done some studies in patients with burns and noticed faster recovery of the tissues and all that kind of stuff. It also prevents excessive breakdown of tissues just for the sake of being this hypermetabolic, demanding calorie state. This puts you back in an anabolic type state, building muscle, burning fat. Well, anabolic to muscle, catabolic to fat. So you're burning fat, building muscle, and getting that general refreshed feeling that growth hormone has been reported to give people. Now, also in that same lecture that we did is IGF-1 LR3, What this is downstream. So growth hormone binds to the growth hormone receptors and stimulates the release of IGF-1. That's insulin-like growth factor 1. The idea here is that it looks like insulin, but is more on the growth side. So this is what does all the muscle building, but it still has insulin-like activities. So that's one of the side effects here, is that it can actually drop your blood sugar if you're not careful with this one. But it's more potent because it doesn't bind to the same proteins that regulate it. It's got a little extra kick and lasts a little bit longer in your system than it just, the IGF-1 in our bodies. By doing this, you get the benefits of hyperplasia. So instead of just hypertrophy, a muscle tissue, hypertrophy is growth of one fiber, essentially. Hyperplasia is the birth of new ones. So you kind of increase your overall potential for muscle growth and size and strength over your lifetime because you put down these new, you're essentially adding seats to an auditorium. People may come in an auditorium, meaning those people are the size and strength and everything. They might leave, but there's still capacity for them to come back. So in the muscle building sense, if you stop something like this, theoretically, because you still have those fibers there, you still have the cells that nourish those fibers there, the satellite cells. If you were to then go back on a high calorie strength training program, you're more likely to get back to where you were faster and maintain that potential to get there. You kind of raise your baseline potential here. So it's kind of cool. Inherently, whenever you're doing that kind of stuff, you're taking the ability of combining amino acids into short peptides and the longer proteins into muscle fibers, into all the tissue and stuff. You're stimulating that activity, and so you're going to stimulate the anabolic activity. It also has some anti-inflammatory effects. This goes back to the earlier slide there, where some inflammation good, a lot of inflammation bad. The right timing and right amount is what really matters here. So in these cases, you're obviously not going to reduce your ability to respond to workout or something because you've dampened inflammation as you would if you took ibuprofen or something like that. This might be anti-inflammatory, but you're still going to get that muscle growth if you're going to take something like this, theoretically. And so in those cases, that anti-inflammatory effect just likely reduces your injury risk and the things that come along with chronic inflammation and weakened tendons and that kind of stuff. Once again, not medical advice, but here are some of the doses and protocols some folks use. That morning fasted pre-workout here, I don't know if you can see my cursor, but it is the concerning one if you don't know what you're doing, because you want to make sure that you have the ability to recognize if your blood sugar is low or just take it with carbs so that you're not going to drop your blood sugars and have an actual health crisis there on your hands. And it's tough to do a set of squats if your blood sugar is in the 50s and you're unconscious. Besides that, if you're going to retain water, joint pains, some joint capsular pain. So the pain you feel in joints when you're kind of retaining fluid is because you're stretching the tissues there. And similarly with tendon pain, if you look at the research by Keith Barr, the pain isn't necessarily from any local inflammation directly necessarily. It's as much as or entirely from the distension, the water in there causing stretch to certain receptors that your body interprets as pain. So more fluid retention, more pain. All right, so in this case, it's IGF-1, it's growth. You do not want to even look at this. You have cancer. There are some correlations between IGF-1 levels and diabetic retinopathy, so proliferative retinopathy, so the increasing of vessels in there that can end up causing damage to the retina. That stuff can be stimulated by IGF-1 most likely, and you never want to be doing anything that can affect growth regulation of a fetus. So I would never even look at a peptide in the case of pregnancy, but this one in particular has those risks. Those main growth pathways that we hear about, mTOR or PI3 kinase or, AKT, things like that, those are the ones that you worry about in cases of cancer and stimulation. But the double-edged sword here is those are the same ones that are going to be stimulating muscle growth. And so it's very tissue-specific important here. So that's why the difference between medicine and poisons in the dose. You want to make sure you're doing this correctly if you're going to be doing this under supervision and understanding what is appropriate and what is just taking on extra risk with a little extra gain out of it. So this one is interesting. KPV is actually the abbreviation of the 3 amino acids in the peptide. It's just a tripeptide. There's 3 of them in there. It has really neat anti-inflammatory effects derived from the gut. It's good for healing of the gut mucosa similarly. So that's why the studies are in ulcerative colitis, and in IBD is the family name for ulcerative colitis and Crohn's. So by reducing that inflammatory aspect, you can see there have been some very significant improvements in the ulcers in the colon, colitis. By modulating TNF-alpha, that's a main inflammatory marker. So they use that in a lot of cases of monitoring for treatment response. A lot of the medications for ulcerative colitis work on that same pathway. So we see the true causative pathway benefit here of how you connect KPV use and improvements in IBD. So it's kind of cool if you can actually, connect those dots pretty straightforward. Because it's derived from the gut, that means it has some oral bioavailability. It means it doesn't need to be injected necessarily to have a theoretical benefit in the GI tract. Also cool. It goes back to the BPC and how that likely improves the safety because you're not going to be injecting things that your gut would otherwise destroy. So that has a unique benefit. It's been generally recognized as safe. However, it's still not approved and can get you in trouble if you're outside of the rules and the FDA on this one. So mechanistically, this would make sense that it would be beneficial in a topical formulation as well. This one works also, besides the TNF-alpha pathway, just more generally NF-kappa-beta. For folks in the medical field, that is a very prominent inflammatory upstream regulatory pathway for inflammation. So if you're going to calm that down, then you would see that TNF-alpha reduction and have general anti-inflammatory effects in the good way, not the bad way, theoretically. GHK-Cu. So this is a copper delivery method essentially. And the point is that our tissues need copper for healing of soft tissue injuries, that kind of stuff. So that's why it's still available in a lot of topical creams and things like that. But because of some less reputable sources selling the stuff in vials, people are injecting that contained all those adulterants, people were having immune reactions, and so the FDA put it on their list. But when it comes to those mechanisms, there's like 4,000 human genes identified here that might utilize copper in those pathways. And so by having that pleiotropic, so multiple pathways effects, this has just a general improvement in wounds and whatnot. So ascorbic acid, vitamin C, it's important in collagen cross-linking. Glutathione is one of the main detoxification pathways in our bodies. So it makes sense we'd have the ability to heal wounds this way. There were some protocols where you use a topical that combines GHK as well as something that's retinol or tryptophan or whatever for skin tightening after weight loss, and you have that excess skin. Essentially, you can improve the elasticity by improving the collagen content, all that stuff, pairing with oral collagen supplementation, so you can kind of get this three-pronged attack on that loose skin. We even have this anti-aging trial up here. Only 71 women, 12 weeks. But despite that, third reduction here in wrinkle volume depth with the comparison. So it's kind of cool and impressive there. This one is available commercially still, only if topical though. All right. So technically, obviously, anything testosterone related is going to be a lot of different applications. But for the sake of healing, it's quite relevant. So, in the same case that during my rehab time, working inpatient rehab, we used oxandrolone, which is also known as Anavar as a brand name. Well, that was used a lot for folks after burns because of that hypermetabolic state I hinted at before. So if you can improve the ability to improve the nitrogen balance, to improve that production of proteins and things like that, you can restore tissue health and fight back on just that catabolic breaking down tissue just to find energy the body does in this hypermetabolic state. Well, more broadly, obviously, testosterone is quite anabolic to muscle. And so if someone has low testosterone, there are two main peptides that we use for restoring those, and then all the benefits for healing after that. So HCG is the same protein that the body produces when pregnant. It is a cousin to the hormone the brain releases called luteinizing hormone that tells the testes to make testosterone. So done correctly, HCG has a very LH type activity. You can boost testosterone directly from that, or you can pair it with other testosterone therapies to prevent testicular atrophy. Maintain your own production while also getting exogenous or external testosterone. But there's actually some studies in other healing contexts for nerve injuries, so it may induce neuronal differentiation. So it may induce neuronal differentiation, and so that essentially can help new nerves heal neurologic injuries. So in the context of spinal cord injuries and brain injuries, that kind of stuff. In this case, they use it in a rat model for spinal cord recovery. That's kind of interesting. It improved when you restore bladder function and locomotive ability, that implies you're getting the distal or the end of the spinal cord function intact. So no matter where the injury was, if you're getting the downstream function back where the bladder function comes from, that's a pretty darn good sign that the recovery is pretty meaningful. In some cases of chronic pain, it may reduce the need for pain medications. So that's a pretty commonly used marker of efficacy for pain relief is, well, does it reduce the psychological urge to use pain meds or need, or like objective need to use these things? That's a good sign that it works for those cases. So let's compare the two. When you're using gonadorelin in these sort of contexts, you don't just give it, once a day or all day, or whatever it is, regularly, because the brain is very complicated in these cases. The pituitary responds to it in a positive way, positive being releasing more luteinizing hormone or FSH, the two hormones that go to the testes and tell it to make testosterone and sperm, respectively. That is in a pulsatile fashion. So over the course of the day, you're getting these pulses of GnRH throughout the day that tells the pituitary, okay, keep releasing those hormones. Cool. If you have a constant stimulation of this thing, so you're just, chronically stable administration of this, the opposite is going to happen. You're going to have a desensitization and you'll actually cause chemical castration. So in this case, when you're giving GnRH, it's going to be in a pulsatile fashion, which is more complicated than most people want to deal with, which is why a lot of times it's going to be HCG or medication like clomiphene that are going to block receptors in the hypothalamus that makes it think it needs to produce more testosterone or estrogen in the body. So those block the receptors in the hypothalamus, which tell the hypothalamus to release GnRH to the pituitary, yada, yada, yada. Those tend to be simpler ways of doing this. Because you can see, my medical advice, those standard practices for GnRH require pulsatile administration. HCG, however, will just stimulate the testes to produce more testosterone without the complicated every 90 to 120 minutes dosing that is kind of ideal to do GnRH correctly. But the benefits here are if you go with something like gonadorelin, you do have the opportunity to have an even better response, but how much is the juice worth the squeeze on this one? Cost is a big difference too. HCG has become much more expensive since it was reclassified and much more difficult to compound. And so because of that, gonadorelin has become a much cheaper alternative, and that's why it's available. Please like and subscribe. It helps us a ton. It lets me spend some more time on this stuff. I love doing these videos. I'd like to do more. And with that kind of feedback, I can justify it to the rest of the team. Thanks for watching.